Welcome to our coffee chats, where we discuss hot topics over hot drinks. For the Data Saves Live superfans among you, of which we can only assume there are many, you may remember that in June last year, 2021, we shone a light on how patient groups have benefited from leading or collaborating on health data initiatives through showcasing 3 different projects from the Innovative Medicines Initiative, or IMI as it is known. For those of you that aren't aware, the IMI is a public-private partnership aiming to speed up the development of better and safer medicines for patients, which you'll be glad to know means involving patients and systems, I should add, at every stage of the development process. We were joined last year by Nigel Hughes, who introduced us to the EHDEN project, which is one of those acronyms which is fortunately a joy to pronounce, and it stands for the European Health Data and Evidence Network. Nigel gave an overview of the project and its aims, and we are delighted now to welcome him and his colleagues back for today's chat. 1 year on, updates from EHDEN and how the team is improving patient outcomes through real-world data. I'm Jess Pacey, and I'll be your host today as we hear from Nige, Monty, and Danny on some of the different considerations of a project like this, and ask some curiosity questions which we hope will help you, our viewers, to understand the importance and value of standardized data platforms, as well as feel inspired about how data really does save lives. In one of the quirks of a pre-recorded session, the eagle-eyed among you will see that we don't have our full panel with us just yet, but that's what post-production is for. We're going to ask each of our wonderful guests today to introduce themselves, their organisation, and their role within EHDEN. So, Nige, can I come to you first?
Thank you. Hello, hi. So I'm Nigel Hughes. I'm a scientific director in the Global Epidemiology Group in R&D at Janssen, and I'm what's known as the project lead for EHDEN. So I'm co-coordinating the programme with my good colleague, Professor Peter Weinbeck in Health Data Sciences at Erasmus Medical Center in Rotterdam.
Hello, thanks also for inviting me to this webinar. So my name is Montse Campruvi. I work at Synapse Research Management Partners as a senior project manager. And in EHDEN, I'm doing the community management role.
And Danny, can I ask you to introduce yourself?
Sure. So my name is Danny Pietro Hamber, and I am a professor of pharmacoepi at Oxford and of real-world evidence at Erasmus Rotterdam. And my role at EHDEN is I am co-leading Work Package 1 and also the research coordinator for the project.
Fabulous. Thanks, Danny. Nige, please could you give us a short summary of what EHDEN is all about for those that may have forgotten, and an update on how your project has progressed since we last spoke?
We are what's known as an IMI project, an Innovative Medicines Initiative project, but it's a public-private partnership. So it's public partners, mixture of universities, academic centres, non-governmental organisations, small to medium-sized enterprises, all sorts of organisations on the public side, working with a whole number of pharmaceutical companies, actually, but all in collaboration in a very open and transparent and program of activities in terms of what we call EHDEN. And essentially what we're doing with EHDEN is, well, we're trying to address, in our way, a very large-scale challenge within Europe, which is, as I've often said myself, Europe is an ocean of data, in this case health data, but it's a desert for analysis. So we have lots and lots of health data all over the European region, but it's actually extremely difficult to work with routinely, shall we say, to generate insights, evidence, all sorts of aspects of our understanding of disease in Europe, treatments, care, outcomes for research and development and so forth. Very challenging to date. And there are all sorts of aspects of that, some technical, some more sociological, so more related to things like ensuring we protect individuals, so citizens and patients and their identities and so forth, and confidentiality, and everything we do is also ethical. So very complex, and EHDEN is kind of working to address this. The way we're doing it is we're creating a large-scale network, really, a collection of different types of what we call data partners, but those could be large-scale hospitals, primary care, networks, claims databases, which contain the data from reimbursement of people's insurance and so forth. Biobanks, which could contain not only data but samples, and then things like small or large data sets, so-called registries, but quite specific data sets that have been collected in different, different disease areas, for instance, different treatment areas. Meanwhile, ensuring that we preserve identity and confidentiality, and that there's no risks attached to this work. We're doing it while creating this network, so linking all these different data partners together with technologies, standardizing their data, because all their data, everyone's data is in different forms, human, machine, and different systems and platforms, languages, and so forth. And so we're harmonizing all of the data, standardizing it to a kind of single form, if you like. We call this a common data model, one we call OMOP, OMOP, but not to get too technical there. But essentially, everywhere we work with each of the data partners, they create a new version, if you like, a copy of their data, mapped or harmonized to the common data model locally. It always stays local in our type of network. It's called a federated network. So we keep the data where it is. We don't create any central database or architectures in the middle where we have to move all the data. Keep it there because it's already hosted, controlled, and secure, and also governance in place, ethics and data committees and so on that have oversight in terms of how that data is being utilized for research. But within this network, we would then create and we are creating a portal where researchers can evaluate different types of data, understand it a bit more deeper with a bit more resolution, and then engage with the data partners and say, look, we've got a research query, a research question. You might be interested in supporting this with your data. And can we, through the system, send you the research question, which could run an analysis locally and then provide the answer back? And that could be done in multiple data partners simultaneously for the same question. So essentially, we're sending questions out, receiving answers, but we're not moving any data. Again, it all stays local and stays protected where it was or is hosted. And then, of course, once the answer's through from all the various centres, it's aggregated or put together, and you have your research response, of course, to your original question. And all this needs to be done within various operating rules and processes and a whole kind of service, if you like, from EHDEN, which is what we're building for the longer term. And then I think second and third, the second part is the second E of EHDEN, European Health Data and Evidence Network. Can we conduct studies? Can we do research? Can we show evidence today and not in several tomorrows that impacts on clinical practice, outcomes for patients, improves our ability to do research and development and so on? And I firmly believe, it's a personal view, that we are challenged right now, and certainly in the past and definitely in the future, with the fact that we often aren't able to do this. And as a consequence, if we don't use data, that can be as bad as we do use data, and obviously risks and perceptions around, again, protecting individuals' rights and confidentiality. But actually not using the data means that we don't generate insights. So we may not be able to treat, care, cure patients effectively, and people are suffering, maybe even dying, because we can't generate the evidence at scale quick enough with high confidence. So we are doing multiple studies and research programs within EHDEN to respond to that. More recently, for COVID-19, like many now, of course, because of the pandemic, obviously we need more answers. We needed them during the last 2.5 years and continuing, but many other disease areas as well. And then lastly, we're working on how we will have longevity, sustainability. So our IMI phase, the kind of project phase, startup phase, will end in April 2024. But we actually already have a legal entity, a not-for-profit, that will continue on, and we're building that startup at the moment to continue on all of this work and expand on all the work that we are doing today, but we'll continue to develop going forward in the future.
Thanks, Nige. I think it's safe to say you've had a very busy year then, since we last spoke.
Yes. We're now, as of 1st of November, we'll be entering our 5th and final full year, so it's 5.5 years in total. And yes, each year has got busier and more complex. But actually, really, as a consequence of the degree of the high amount of success we've had, far more than our probably original aspirations ever were. And that's a good thing, but it has meant that we've really had to be very adaptable, I suppose, and ensure that we can respond appropriately to this really large expansion of the network and all our data partners and researchers and many others.
I think what you've touched on a lot of the issues that makes health data such an unattractive topic for some, and the fact that it's messy, it's complicated, there are a hell of a lot of people involved, but unless we do start taking those steps to clean it up, as it were, to standardize it and make use of it, then we're not actually going to see the advances that we want. And to your point, there's a lot of discussion around donating data and how that's used, but to not use it would really be the kind of highest crime that you can think of, as much as some of the concerns around consent and privacy, which are equally important. But if you donate it, you want to know that it is going somewhere and it's being useful, and drawing insights.
Yeah, I couldn't agree more. I think they put it very well, actually. I think that's a very nice summary of my long sentences. But but no, definitely, I think in terms of, we need to do the right thing, but equally, by not doing it, i.e. using the data and generating the kind of insights we need to guide the care and the treatment and research and development. I mean, this is in today's world, I think is really resulting in harm, actually. So I think that's extremely important.
We spoke about the importance of actually generating insights from the data. Can I ask, what have been the most significant insights that you've generated so far?
We looked at two different types of treatment for osteoarthritis, where we looked at partial or total knee replacement, for instance. And we actually ran a study using data from different databases around the world, all standardized, and compared that to a real world study where they actually looked at the outcomes of people who'd had these operations over a 5-year period. And we could see differences in terms of which type of people and what age they should be in terms of having this type of intervention, a total versus a full knee replacement. What about things like pain relief and complications afterwards, or indeed the need for revision, i.e. the knee replacement didn't work very well and needed to be done again. So we could do all that looking at data sets, international data sets, with huge numbers of patients, and all of that was published as well. And then running through, we've done various things, including with COVID-19. We've done numbers of studies now, a large number of studies actually. If you look on EHDEN.eu again, you can look at some of these outcomes. But we looked at everything from the early stages in March, actually, onwards of 2020. So when the pandemic was only really getting going, we were already looking at what were the kind of treatments being used at that time and how effective they were, and what were the kind of side effects, and were there any risks in reusing drugs from other diseases to treat COVID-19, things like hydroxychloroquine, which everyone at the time was suggesting ought to be a good treatment, in fact wasn't. We've also looked at things like vaccines, what's been the uptake of vaccines, the efficacy of vaccines, what kind of side effect profiles should we be looking for in the general population anyway, and then versus people who get the vaccine. So you can already see a very broad and very diverse a different kind of portfolio, a collection of different research areas, and many of our data partners are doing research in those areas, from pregnancy studies, pediatrics, so in children, so forth, right through to late stages and so forth, and looking at all the kind of chronic diseases that we're dealing with, things like type 2 diabetes, for instance, or cardiac heart aspects. So very, very diverse, very broad, and a lot of publications, and already some impact, we think, on things like guidelines and on practice.
We've heard from Nigel around what the project's aiming to do and what a vast amount of work it's got in terms of people on board as partners, 166, which is just flabbergasting. Montse, if we can speak to you a little bit more about working with partners, how did EHDEN help patient groups to understand the concepts around the project? Because as we've heard, they're not easy concepts.
Well, so in EHDEN, we designed this community management role to precisely interact with all our data partners, because we felt that having a devoted person to converse with them, to explain all the process, will help a lot. And we found that this is very, very useful. We know them, we know in which part of the progress that they are. So we, after all this time, we feel that this position is extremely useful for the project and for the community at large. So we are working with them hand in hand. In addition, we also organize periodically meetings that they can all line together and explain what they did, the work that they do. And in parallel, we are also seeing natural collaboration between data partners. So we see that especially in the same countries, data partners tend to speak among themselves in a line on the work that they do, which is the natural and the spirit of collaboration that is also part of the spirit that EHDEN wants to endorse.
Lovely, thank you. And how have you managed to build trust and open collaboration among partners? I suppose a follow-up question to that, if you want to include in your answer, is also, were there any challenges to building that trust?
I would say that one of the main aspects on that sense is to show that we have a clear process in terms of the signature of documents that data partners are expected to sign, and also clear steps in the ETL process that they need to go. Additionally, the collaboration with the Odyssey community, I think it's also a good source to build this trust. And a full panel of experts working in the project and also trying to provide help when there are questions is also viewed as a great source for having this trust into the network that EHDEN is building.
Fantastic. I mean, I loved also the sound of the training that you're offering earlier, because certainly for community partners that we've had experience engaging with for Data Saves Lives, there's a big gap just in understanding what those structures are that surround data governance and what are the steps to get those in place. So it's great to hear that you've got a robust mechanism to do just that. Last year, we talked about the role that patient groups have in leading or collaborating on health data projects like EHDEN. Just wanted to know your view again for the audience in terms of how the work of initiatives like this can help to directly empower patients in the community at large.
So I think it's an extremely important question, and it's an excellent one. And I think that already we've seen some really nice examples of how this is happening. So I'll take at least a couple first. The first one is around actual conducting of research, having patient involvement in that. And I mean patient involvement by actually engaged actively in the research process, not I'm a patient, here's my story. I'm not to say there's not a good place for that, but there can be a lot more beyond that. So an example is we worked with a sister project actually in IMI called Pioneer. It's very much like EHDEN, but working specifically in around prostate cancer in men, for men, all of who have had or have prostate cancer at the time. And they were involved from start to finish and actually actively engaged, with all the other researchers, the clinicians, the coders and programmers and so forth. But we're really active in terms of using their own knowledge and their own awareness of living actually with prostate cancer and having treatments and so forth, but to inform the actual study-a-thon process. And what we were studying there was, so currently when you are treating prostate cancer, there's kind of three options that clinicians and patients face. One is we should actively treat you as a man with prostate cancer. It needs treatment like now or soon. Or we'll monitor you, and that might be actively. We'll keep an eye on you, we'll intervene every now and again, we'll do diagnostic tests and so forth. And if things change, we might treat you. Or something called watchful waiting, which is, well, we won't do either of the first two things, but we'll just see how it goes. It may be that, unfortunately, you might have problems with other diseases, which are more of a problem than prostate cancer, or you might be quite old and so on. Maybe the treatment is not a good idea. So one of the questions everyone has as clinicians and definitely patients is, if I'm in any of these three groups, was that the right decision? How do I know now, 5 years' time, 10 years' time, was the right decision? That might become quite apparent. So actually we used, again, very large data sets, again, all standardized in this common data model with all these research tools. But actually, again, there was patients who had experienced this. They'd gone through this process, they'd had a diagnosis, they'd had a care package worked out, internal care plan worked out in terms of what they should do. That was invaluable, I think, of reinforcing the clinical viewpoint, but also ensuring researchers fully understood what kind of things we were looking for, how best to answer the question, so on. And I have to say, I think it was a remarkable study-a-thon, really very importantly because of the level of involvement from patients. So I think that's fantastic.
Yeah, really, really great insights. Thanks, Nige, for that. And it is interesting that there has been such a separation before from, now we call it public patient involvement, but the fact that didn't exist before is surprising in itself when it comes to clinical research about diseases that people are living with, which actually ties me on to my next question, and that's for Danny, actually. So that question is, how can a greater incorporation of patient-reported outcomes, or PROs as they're often referred to, help to standardise healthcare, and what impact does that have for patients?
So patient-reported outcomes are a recognized outcome for many research studies, of course, clinical trials. In observational research and in real-world evidence in particular, we always have a feeling that most of the people that participate in trials are not representative of the wider population. So collecting information on PROs amongst people who are not involved in such studies is important. There isn't near enough amount information on PROs in the general population or in people who are more representative of the community. So I think that sort of information is fundamental, and the only way we're going to collect it is if we start recording PROs in settings that are not so akin to research, like in smaller hospitals, in the community, primary care, or potentially using, patient-generated data like cell phones and the likes, right, which has been, as you probably know, trialed quite successfully in many countries, including here in the UK. That information is very important, not only to understand the impact of conditions on people's health, but also to figure out the value of innovation. When there is a new technology, typically we want to look at the impact of that technology on people's health, and these patient-reported outcomes are probably the best way to measure that in a scientifically sound, but also patient-important or patient-relevant way.
Thanks, Danny. I'm just going to pick up on one of the points that you made that was interesting, in that there's the sense in the research world that the patient population represented in clinical trials isn't truly representative of the wider community at large. So on that point, could you talk to us briefly about how you've ensured that the data collected in EHDEN is as inclusive as possible to eliminate, obviously, the kind of exclusion that we see sometimes in trials, but also digital exclusion in this case of certain groups and minorities?
Sure. I believe that the kind of data we're using in EHDEN, which is called sometimes real-world data or routinely collected health data, is by design more likely to be representative of the wider population, because we collect that information in routine care. So anyone attending a clinician or a healthcare professional will get the data, potentially contributing to these databases. In EHDEN in particular, we have, I believe, mostly three types of data that are being used: electronic medical records, health claims, and registry data. Most of those, if not all of the data partners that we have involved, when they apply for funding from EHDEN, we ask them whether they have very specific subpopulations included, where they are excluding people from, certain socioeconomic background or people from certain ages. And most of the times, if not all of the times, the applicants report that they are collecting data on everyone. So only that, by definition, already gives you a very representative population. But on top of that, many databases are really grounded in the community, like primary care data sources, for instance. Of course, anybody that has a GP or is registered with a GP will be potentially contributing. Of course, in the end, we always rely on patients to contribute, right? So people can always opt out of these databases. And that kind of hinders, again, the representativeness of these databases. But if people are willing to contribute the data in a pseudonymized manner for research, then these databases are as representative as it gets, really, of the real population out there. Very, very different from trials, which, of course, tend to happen in very academic settings, big hospitals, and the likes.
Thanks, Danny. And Nigel spoke earlier about the fact that in EHDEN, the data isn't moved. It's kind of decided that it's safe at the point of collection. But obviously, there is this huge amount of work being done to make sure that it can be used cross borders. So thinking about the complexities of that and how data is transferred, what safeguards are in place to ensure that security of the health data in the EHDEN project is protected?
So in EHDEN, as Nigel mentioned already, we use this privacy by design framework where we never access patient-level data ourselves. So the EHDEN collaborators, like when I'm doing a study, I don't have access to patient-level data. It is the data holders or the data stewards that have access to that data. And what we do is we ask them that they create a new instance of that data that has been reformatted in a format that we know and that we are familiar with, and that is common. That's what we call a common data model, right? Where age looks the same in all databases, all the conditions have the same name, and we can then, by doing that ourselves, without access to data, generate analytical code, software or programs that will then run on people's data without accessing the data. That's the way we secure privacy within EHDEN. On top of that, because of course, people could still, by mistake, send us data instead of results, we have programmatic ways to make sure that doesn't happen. Like we will suppress any cells in a table, for instance, or in a database that have less than 5 people or 10 people, depending on the local regulations, which are different in different regions of the world.
Thanks, Danny. And just a final question for you before we take a look at some of the broader learnings from the project that might help some of our viewers apply to work that they're doing as well. We've explored in the past on Across Data Saves Lives, it's a common theme just around the ethical tensions around consent when the data is used for one purpose, but then over time, and particularly as technology becomes more sophisticated, we start using it for other purposes. Mm. In your view, how do we best approach this issue so that we can make the best use of data over time and work towards overcoming this tension of consenting to something once and knowing that, particularly with continuous monitoring or kind of data records like you spoke about in primary care, you're not constantly being asked about how your data is being used?
Yeah, so this is a big area where I don't want to claim any specific expertise because I don't have it. But it's kind of obvious to me that, of course, the easiest clause to exit a database is an opt-out clause where one can just opt out at any time, right? So even if you have opted in, if at some point you decide that you don't want to contribute your data anymore, you have to have the opportunity to say, hey, I don't want my data to be used. And that is what is being used across most of the part of Europe, or at least across all the European regions that I've collaborated with. I think that's probably the easiest way to secure that if you change your mind, and you don't want your data to be used for any other purposes, you can always opt out and then you have to be deleted from that data.
Thanks, Danny. And I think there's a little bit of work to do then in terms of educating the community on what their rights are concerning data, which of course is some of the context and some of the discussion that's being had around the health data space, European health data space, to address that, which does bring me on to this discussion of broader learnings for this and the long-term impact for the EHDEN project. Maybe Nigel, I'll come to you. How do you think the European health data space will impact this project?
Yeah, that's a very interesting question. This is possibly one of the most challenging legislation in recent years, and one of the most complex as well. And I have good authority that this is definitely one of the most complex legislation that's gone through the Commission for a long time to Parliament and the Council. So it's extremely difficult to say actually what will be the end result. We'll have to wait and see. I think the principles, having basically networks that support clinical care and then also support research, clearly make a lot of sense. But actually how they're going to be implemented, operated, governed, data protected, and bearing in mind that every member state is different, and healthcare is really driven by the member states, by countries in Europe. It's the European Commission and that kind of apparatus has a role, but at the end of the day, health is what's known as delegated. It's managed by the member states. So, it sounds great in principle, and it's appropriate to think about a European-wide network, and in some form or fashion, I suspect that will happen. Technically, there's not necessarily a reason not to, but actually there's an awful lot more to happen, including with the member states and with all these different challenges to be addressed. So I think we need to keep everything in context, that whatever happens, it won't be for years. This is not going to be overnight. No. It's not going to be European Health Data Space.
It's going to be after full year 5 completion of EHDEN.
By a long way. Yeah. So I think ultimately the best that could happen, European Health Data Space or otherwise, is that we'll see a kind of complementary kind of ecology or mixture of different approaches, because not one approach. I mean, EHDEN doesn't solve everything, right? Although we'd love it to, but it doesn't solve every problem, and it doesn't meet every research need. And there are other approaches that can do that. So actually, the best thing is to have a mixture of different approaches that will allow us to look at data in different ways, captured in different ways, and researched in different ways, but ultimately to give the answers that we need. So I think the very best thing that could happen is that we end up with this interoperability, of different processes and systems and projects going forward in the future, and it's much more tighter in terms of collaboration. But I think it's naive to think that one thing, including European Health Data Space, will fix everything. That doesn't make sense.
Well, that's a huge disappointment, because we all were just looking for that magic bullet, as they say, that's going to fix everything. We're in this kind of reflective stage of this project now, looking ahead and what's going to be and who's going to kind of carry the baton moving forward. But from what's been, what would you say are the biggest learnings that you've had since the project was initiated?
Well, this is a difficult question, but also very promising, as what we, in any case, want is to continue this collaborative spirit, maintain the network alive, and the dialogue with all our members. I think it's crucial to keep all our members engaged into this community.
In terms of the next phase of this project, what are the plans after your leadership of it ends?
We don't see the end of the project as the end of the effort. We are forming a strong coalition of colleagues who want to continue working together, who want to generate evidence, and who see the end of this project as the beginning of something bigger. We are, of course, hoping that we will be able to, rally the troops and gather funding and continue doing this in a very professional way. But I think there is a very strong community of open science collaborators as well who want to continue generating evidence using the EHDEN network. So to me, I think there's basically 2 parallel tracks that are going to happen. One is that hopefully the open science community will be very much strengthened in Europe after EHDEN, and will continue working together to generate evidence in this open science space, where, by the way, many citizen scientists will be involved, because we are all patient and we can all contribute to science in many ways. And then in parallel to that, our hope is that we will have some sort of non-for-profit institution that will help us continue the collaboration going forward to do research for the right reasons and to improve patient care.
Thank you so much. And it's great to hear about sustainability of projects and initiatives like this, because it is hard when it lies, or the power lies in a few people and a few people with historic knowledge, to make a project continue. So actually the way that you're setting it up, always thinking about that exit plan and how you do share that responsibility and let the network live and breathe by itself, is really positive to hear, and not too dissimilar to the Data Saves Lives initiative, actually, which is aiming to help other people continue that conversation conversation and make the topic of health data a little bit more approachable. So with that, I'd like to thank you all so much for sharing so much knowledge and so many insights with us. I'd love to be able to say, like we did last year, see you next year, because obviously, as you just said, this really is going to continue living and breathing. So yeah, let's see how we go by June 2023. But for our viewers, you can stay up to date with all our data debates and data discussions like this, lots of our panel members and our experts, by following us on our social channels, which you'll be able to see at the end of the webinar, and keep looking back at our website to see events just like this that we promote. And with that, thank you so much to our panel for joining us, and wishing you all a great day wherever you are.